Okay, great.
Right?
All right.
Please,
Oh,
floor is yours now, Max.
okay. Thank you so much, Dr. Wasim, for that introduction. I had the honor and pleasure of meeting Dr. Wasim. He spent some time in Baltimore, and he's become a friend and a wonderful colleague. So I want to thank him for this opportunity to speak with all of you today. Once more, my name is Max Plittz. I am a head and neck endocrine surgeon. I'm currently the fellow at Johns Hopkins University. Um, and I'm here to talk to you about molecular profiling in thyroidology. After Dr. Hotiana's talk, this is a good segue into talking about the uses of molecular testing, the implications in decision making. I have no disclosures. So for today, we're going to do just a very brief background on thyroid cancer. We're going to talk about molecular profiling or genetic testing, its indications and uses, and what the ATA guideline says about that. We'll talk a little bit about genetics of thyroid cancer. We'll talk about molecular profiling options, as well as considerations and clinical decision making. We'll go over a couple of cases to kind of round everything out. So briefly, thyroid cancer. So in the USA, thyroid cancer accounts for about 6% of cancers in women and less than 3% of cancers in men. And accurate detection and diagnosis will help with appropriate treatment strategies and provide patients with information for treatment counseling. As alluded to before, fine needle aspiration is an important diagnostic tool for the initial evaluation of these nodules. It's simple, it's safe, it's accurate, it's very cost effective. We know that 80% of nodules are benign, but some are malignant, but some come in this category, about 15 to 30%, that is indeterminate based on the Bethesda classification scheme. Indeterminate thyroid nodules are challenges for cytopathologists and clinicians as well. This can lead to higher healthcare costs, and in almost 20 to 25% of these indeterminate lesions, from a couple perspectives. One, if a patient comes back with an indeterminate lesion and you don't have the access to molecular profiling, your option is to repeat that biopsy, or sometimes have to do a diagnostic surgical lobectomy, which that could cost extra money and be burdensome not only to healthcare costs, but also to the patient if they have an unnecessary surgery for something that was inevitably benign. The application of molecular testing in 2015 with the ATA guidelines was accepted. It was also accepted by other entities as well. The objective of molecular testing is to provide more of a definitive guidance to assist with decision-making and management approach. It's basically arming us with more knowledge and more tools in our toolkit. And numerous studies had showed that there's high sensitivity and accuracy when applied to certain cytologic specimens. It is now used as a tool for clinical management, specialized therapy, and also can garner some knowledge and prognosis for certain lesions. Most of the applications of molecular testing is for Bethesda 3 AUS or FLUS lesions, and Bethesda 4 suspicious for follicular neoplasm. However, it can be applied, not routinely, but can to Bethesda 5 and Bethesda 6 nodules. And that was written in the American Thyroid Association guidelines, A19B, specifically looking at the use of genetic testing, their genetic markers in the actual diagnosis in cancer, because that can have implications in prognosis, but also could glean some information on how aggressive certain cancers can be. Specifically, we think about using molecular profiling. If it's positive for RET, you start thinking about medullary thyroid cancer, and that opens up the discussion for more familial causes of medullary thyroid cancer, and can lead a clinician to expedite a workup for working up pheochromocytomas or other conditions. If there's existence of a TERT promoter, as this is known to be associated more with aggressive cancers such as tall cell variants or more aggressive papillary thyroid cancers, especially in conjunction with other mutations. RET PTC translocations and PAX8, these fusions are also tend to be associated with more aggressive PTCs and follicular thyroid cancers, respectively. As this was touched on before in our previous presentation, this is the Bethesda classification schema, basically breaking down all the options for cytopathology for FNA nodules. And then when you look at the Bethesda 3 and Bethesda 4, you can see that the estimated predicted risk of malignancy of these lesions collectively is between 5 and 30%, with the actual risk of malignancy in these nodules between 14 and 25%. So we use genetic testing for this middle group, what we call, quote, the gray zone, and that allows us to give patients and also clinicians more information to determine, is it best to take this nodule out or is it best to watch it because it is likely benign? I think one thing that is underestimated is understanding the genetics of thyroid cancer. So I truly believe a comprehensive understanding of the pathogenesis of thyroid cancer and its molecular pathways responsible for thyroid cancer is critical to using and understanding molecular profiling. And so looking at this image right here, we know that a thyroid gland or a follicle is at the top, and it's split into two different types of cells, a follicular epithelial cell and a parafollicular C cell. Of course, parafollicular C cells can turn into medullary thyroid cancer, which you have all the way on the right side. And with follicular cells being separated into differentiated thyroid cancers or undifferentiated thyroid cancers. In undifferentiated cancers, you think about those poorly differentiated cancers or anaplastics, which tend to be very locally aggressive. And then within differentiated thyroid cancer, you're thinking about PTC, follicular thyroid cancer, FTC. And within PTC, you have variants. You have your classical PTC that tends to be more indolent, but of course you also have follicular PTC and tall cell variants. There's other things like hobnail variants, but understanding those and understanding which are the ones that are more aggressive, and that can sometimes be gleaned in your molecular profiling. And so there's a lot of genes that are associated with thyroid cancer, and this table basically delineates a few of those. The ones being the most important is understanding RAS, R-A-S, and BRAF, and knowing these pathways. Other ones that are associated with cancer, as I alluded to before, is TERT promoter, any translocation such as RET, PTC, NTRK. These are the ones that we need to be aware of, as those can be more associated with more aggressive features. Okay, not to bore you with the genetics, but if you look on the right side, this is a comprehensive look at the pathways of the genetics of thyroid cancer. And so as you can see, it can be a little complicated, but if you look on the left side, kind of breaking it down, there's two pathways. There's the BRAF that turns into papillary carcinomas, and then there is the RAS pathway. What is important to know is when you're looking at these molecular tests, when you see a BRAF V600E mutation, the genetic testing company is going to tell you that's about a 95 to 99% risk of cancer. And the reason is because of the genetics. If you have a BRAF mutation, specifically V600E, based on how the pathogenesis of cancer, once you get that one hit mutation, it's going to be a cancer, just based on how downstream it is within the cell. Conversely, when you have something like a RAS mutation, so an example would be HRAS, NRAS, or KRAS, you're not going to get 99% risk of cancer, but you're going to get something more like 70% risk of malignancy or follicular neoplasm, NIFT-P, or follicular carcinoma. And the reason is, again, because RAS does require more than just one mutation. Rather, it's a two-hit kind of like that two-hit hypothesis, where you need multiple mutations within the RAS line in order for you to end up with a follicular carcinoma. More importantly, when you have a RAS mutation, diagnostic lobectomy is going to be the only way to truly be able to characterize this into an invasive follicular carcinoma or something like a NIFT-P. And so it's important to understand that when you have certain mutations, the likelihood of cancer is so high just based on how downstream it is within the genetics of thyroid cancer. And so our primary goal of thyroid surgery for these indeterminate lesions, or sometimes these suspicious nodules, is to establish a histological diagnosis and definitive removal. All at the same time, we're trying to reduce the risks associated with remedial surgery. So in the setting of someone who may have a large nodule greater than 4 centimeters, that's a Bethesda 3 AUS, if we were able to glean more information about that nodule with molecular testing, we might be able to counsel that patient, hey, based on this genetics, a total thyroidectomy up front would be more reasonable based on the size of this nodule, as opposed to doing just a diagnostic lobectomy and getting final pathology, realizing that we need to do a completion. These things still happen, and we deal with this every single day in Johns Hopkins, but having more information allows us to best counsel the patient and reduce the odds of needing revision surgery. Again, molecular profiling may shift the likelihood of cancer. So I have this image of a balance where it could shift the clinician to recommend either observation or surgery. All right, so as far as what are the options, in the US, there's 3 major molecular profiling companies. I have no stake in the game. We use all 3. There's ThyroSeq, Afirma, and Thigen. ThyroSeq was created by the University of Pittsburgh Medical Center. Afirma gene sequencing classifier and expression atlas. This is by Veracyte in San Francisco. And Thigen, which is probably the one that I don't see that often. That's out of Parsippany, New Jersey. But all 3 are excellent. They all offer very high negative predictive value, as well as a reasonable positive predictive value for the evaluation of these indeterminate thyroid nodules. And also that they have been studied thoroughly and are validated. We have experience with all 3, but again, like I said before, I have no disclosures or special interests. I chose to focus on Afirma because this is one that we use often in Hopkins, but we also have experience with ThyroSeq and other molecular profiling companies as well. And they're all fantastic. So the molecular testing pathway is a patient presents with a sonographically suspicious thyroid nodule. The patient needs an FNA biopsy of this nodule. And so I would either perform that in my clinic, or a radiologist would perform it, or one of our endocrinologists will perform the FNA biopsy. And our pathway also includes that reflexively we will send an extra few passes automatically for molecular testing in the event that this patient comes back as a indeterminate nodule. Bethesda 3 or Bethesda 4. And so there will be an addendum on the cytology with the molecular testing results, okay? In some situations, if a patient has a Bethesda 5 or Bethesda 6, we'll also have molecular testing in the event that we're concerned for aggressive disease, warranting maybe systemic therapy or something that may alter the course of this patient. Other things that play a role in why we would send genetic testing is age, if they've been exposed to ionizing radiation, or a very strong family history, or if they have any genetic conditions. When we use Afirma, we first send a gene sequencing, and then the Afirma pathway will then initiate the expression atlas if there is a suspicious mutation found on the molecular profiling. All right, so this is kind of that pathway that I had alluded to. So on side A, you'll see we have a thyroid nodule. We have FNA for cytology and Afirma that's automatically collected. If that comes back as Bethesda 3 or 4, then Afirma gene sequencing classification is then done with malignancy classifiers. If it is benign, we would recommend clinical observation or other modalities if this benign nodule is bothersome to the patient. That's a discussion for another time. If it comes back as suspicious, that's when the Afirma Expression Atlas is then performed. And essentially what that does is it looks for specific gene markers. And that allows us to personalize the treatment and offer the patient options and counsel them on what are the next steps. The same thing can be applied for Bethesda 5 and Bethesda 6 lesions. Again, if we have a diagnosis of suspicious for malignancy or malignant, that's automatically going to trigger us to get the Afirma Expression Atlas and find a genetic marker that will help personalize the patient's treatment. Like I alluded to before, if we have a diagnosis of thyroid cancer that's possibly warranting systemic therapy, such as if there's already a metastatic disease to lymph nodes, using or identifying markers early in the patient's treatment course will allow us to determine if systemic therapy is needed in the future if they have cancer progression. So, Dr. Hotiana showed some examples of what a molecular profiling report looks like. So I have two here. I have ThyroSeq and Afirma. Again, they're both great. I don't have any skin in the game with either company. They're both fantastic. So looking at the ThyroSeq report, this is really important. This patient came with a Bethesda 4 lesion. It was 4.12 centimeters, the size of the nodule. And so although it was an indeterminate nodule, the patient's probability of cancer based on the ThyroSeq was quite high. So it came back as positive, and the probability of cancer was around 90%. And the reason being is if you look at the gene mutations that popped up, there was an NRAS mutation and also a TERT. So you can counsel this patient now who has a greater than a 4-centimeter nodule, hey, you have two gene mutations that could very likely increase the risk of cancer. But not only that, that this could be a more of an aggressive form of cancer. And traditionally, a patient who would have had a diagnostic lobectomy, you can now counsel them that, hey, you have an indication for a total thyroidectomy up front. So not only did this was this more cost effective, but it armed the patient with more information to make an informed decision on their care. And so I think that's a very important utilization of molecular profiling is if it's a large indeterminate nodule, you come back with a genetic marker that's going to be more than likely that they have cancer, you can counsel that patient on their surgical options better. On the other side, we have Afirma here. So this is an example of a patient who had a Bethesda 3 nodule. It was 1.4 centimeters on the right side. Afirma GSC came back suspicious, so the risk of malignancy was approximately 50%. And the mutation that they found was a BRAF, but specifically a PK60, K601E. This is not the same as BRAF V600E. And because this is also associated with NIFT-Ps, follicular adenomas, or other follicular lesions, we assign this a 50%. And so what we tell the patient is, hey, there's a 50% chance it could be cancer. There's a 50% chance that this could be benign, or this is something like a NIFT-P. And so how we counsel that patient is essentially it's a coin flip. You do have the option of watching this, but also doing a diagnostic lobectomy would be your next best step. Two other examples here. If you look on this side, on the right side, Afirma, this one is benign. This patient had a 1.5 centimeter Bethesda 3 nodule, and the Afirma came back as benign and approximately 4% risk of cancer. And so that's another thing that you need to counsel your patients is that it's not 100%. But it does lower the risk significantly. So you tell the patient there is a less than 4% chance that this nodule is cancer. Clinical observation is warranted, but some patients may choose, hey, I don't want to be dealing with this. I would prefer definitive treatment. And you'd be surprised, and anecdotally, sometimes you run into situations where your molecular testing and your cytology is telling you, hey, this is more likely benign, but you may be coming back with something like a cancer. And most of the time, the cancers that tend to evade molecular testing and cytology tends to be the follicular cell carcinomas or the Hürthle cell carcinomas. So it's something to keep in the back of the mind. Another example is a suspicious for malignancy. So this is a Bethesda 5 nodule. And as you can see on the Afirma expression atlas, that you have this translocation NTRK ETV6. And specifically, this translocation is high risk for more of an aggressive cancer. And in fact, these translocations are strongly associated with ionizing radiation. So this patient could have grown up next to a power plant. These kind of translocations were associated with the Chernobyl nuclear accident, but also if this patient had received ionizing radiation as a child for a history of head and neck cancer, lymphoma, or other neoplastic process. All right, considerations. So molecular testing is not 100% perfect. And there are some clinical scenarios that make the clinician highly suspicious for malignancy despite favorable molecular profiling. Ultrasound is a very powerful tool. So if you are a very skilled sonographer and you see a highly suspicious appearing nodule on ultrasound, despite your molecular testing suggesting it's benign. So if there's evidence of extrathyroidal extension, punctate echogenic foci, or those microcalcifications, or very irregular borders, you can have that conversation with your patient saying, I don't like how this looks sonographically, although it appears to be benign. And you can just have that open conversation and say, hey, everything's suggesting it's benign, but maybe we should consider taking this out. Another thing would be rapid increased growth from the time of the initial biopsy. Some things that we've been seeing more are regrowth after ablative techniques. I can think of one patient about 2 weeks ago who had a radiofrequency ablation about a year or two prior. Had initial reduced size of her nodule, but then had some significant regrowth to about 7 centimeters. And she started having some compressive symptoms. This was a nodule that was biopsied multiple times that was benign. In fact, one time it was Bethesda 3, and the genetic testing suggested it was benign. We took that patient to the operating room, and it turned out that she had an encapsulated angioinvasive follicular carcinoma. And so that's something to be mindful that if you're having regrowth after ablative techniques, something should tip you off that maybe something is growing because it's a cancer. Obviously, if a patient has a recurrent laryngeal nerve paresis or is any concern for airway involvement ipsilateral to the nodule that you have biopsied, you should be highly suspicious for cancer. FDG avidity, if it's highly FDG avid on PET CT, your clinical suspicion should be high. Obviously, if there's any concern about metastatic lymph nodes to the neck, and if those come back positive for a thyroid cancer, then absolutely the molecular profiling is wrong. That's very uncommon, but not impossible. And like I alluded to before, follicular or Hürthle cell carcinomas are the ones that tend to evade our genetic testing and our cytology. Those are the ones that tend to be the sneakiest. And so always just keeping that in the back of the mind. So clinical judgment with all pieces of data is critical, and with the patient being at the center of the decision making. I think that's most important is these molecular testing gives the patient more information and allows them to make the most informed decision about their care. All right, so let's talk about some cases real quick. So case number one, we have a 19-year-old male presents to your clinic with a 1.9 centimeter right thyroid nodule. This is found by their primary care physician. They have no past medical history, no history of radiation exposure or family history of thyroid cancer. You do an ultrasound, and sure enough, they have a right 1.9 centimeter thyroid nodule. They also have an isthmus 1.5 centimeter cystic appearing nodule. Cytology, that nodule came back as Bethesda 3, atypia of undetermined significance. We sent that reflexively for Afirma, and that testing comes back as 70% risk of malignancy, or NIFP, with an NRAS mutation. So we counsel this patient that they have a nodule, that there's a 70% chance risk of malignancy, or NIFP. It's 1.9 centimeters. You take into consideration their age, they're 19. If they were a pediatric patient, you might be considering doing a total thyroidectomy. However, you talk to them that there is also a chance that this could be benign. So you offer them surgery. The patient chooses to move forward with a right thyroid lobectomy, and sure enough, the final pathology is follicular adenoma, and that fits with the genetic testing that we have that showed that it was a NRAS mutation, and knowing that there's a chance that that could be a follicular neoplasm. Going to case 2, now we have a 36-year-old female with a history of Hashimoto's thyroiditis with a left superior pole 4.6 centimeter thyroid nodule that was found on ultrasound of the thyroid. Specifically, this is a TIRADS 4 nodule. It has irregular borders. She does have some right thyroid nodules, which are sub-centimeter. This comes back as Bethesda 3 AUS, but our genetic testing on Afirma shows that it's a 95% risk or greater risk of malignancy with a BRAF V600E. Now, armed with this information, with a 4.6 centimeter thyroid nodule, you can counsel this patient up front and tell them, hey, you have a thyroid cancer that is very likely a papillary thyroid cancer, but because of the size of the nodule, using the American Thyroid Association guidelines, a total thyroidectomy would be indicated in this situation. You do an ultrasound of the soft tissues of the neck, and there's no evidence of central or lateral neck lymphadenopathy. You discuss with the patient options for surgery, and she ends up moving forward with a total thyroidectomy. And in fact, you perform a left central neck dissection for suspicious intraoperative lymph nodes, despite your ultrasound being negative. And your final pathology is multifocal PTC, and 6 out of the 10 of those central neck nodes were positive. Now, without molecular testing, you may had to have done a diagnostic lobectomy, for which you would have found that this was a 4.6 centimeter PTC, maybe multifocal PTC. You would have offered this patient a completion thyroidectomy. But armed with this knowledge, this patient was able to make an informed decision saying, hey, getting my thyroid, my whole thyroid taken out up front saves us some time, but also is more cost effective. And lastly, my third case, this is a 24-year-old female with no past medical history and an incidentally found right thyroid nodule and CT imaging for neck pain. She subsequently gets an ultrasound. It shows a right middle pole adjacent to the trachea, 1.6 centimeter TIRADS 5 nodule. She does have some indeterminate central neck lymph nodes. FNA biopsy came back that this was a Bethesda 5, suspicious for malignancy. However, your Afirma testing was sent and shows that there is not only a BRAF V600E, but she also has a TERT promoter. And so armed with that knowledge, knowing that BRAF and concomitant TERT promoter, this patient is at high risk for a more aggressive form of cancer. The patient elected for a total thyroidectomy plus or minus a central neck dissection based on these findings. And sure enough, intraoperatively, this patient's right recurrent laryngeal nerve is very adherent to the tumor, but completely intact with a positive stimulus. There's no evidence of perineural invasion, but sure enough, the final pathology in this patient was a right 1.6 PTC with tall cell variant. And 9 out of the 10 of those central neck lymph nodes that you took out were positive, and she had evidence of extra nodal extension. This is a patient that you would consider strongly for radioactive iodine. But armed with the knowledge that we had, because we were able to detect that she had a TERT promoter, we were able to expedite and give her the appropriate surgery up front. So in conclusion, molecular testing arms the clinician with more information and allows us to counsel the patient on their options and help them make the most informed decision. It enhances our ability to predict indeterminate nodules, essentially increasing our predictive power. It allows us to do less surgery on benign nodules, which equals saving money and unnecessary surgery. But it can also provide information to surgeons preoperatively on the genetics of the tumors and help counsel patients and glean information to determine, is this going to be a more aggressive cancer that might need a bigger surgery than just a lobectomy. Thank you very much, everybody, and I'll step down for any questions. These are my references.